It is my pleasure to introduce our next speaker, Dr. Uche Megwalu. Dr. Megwalu is a professor in the Department of Otolaryngology Head and Neck Surgery and serves as the chief of our comprehensive otolaryngology division. And his research focuses on the important issues around health disparities. And we're really happy to have him here today sharing some of his work. So welcome.
Hey, so thanks everyone for having me. As Heather mentioned, I'm a general otolaryngologist, but I do care for a lot of patients with head and neck cancer. And actually, head and neck cancer actually is one of the major areas of research for me. Today, we're going to be talking about disparities in head and neck cancer outcomes. I don't have any disclosures for this talk. Let's start out by talking about two patients. Okay, so Ben had stage 3 oropharyngeal cancer and is disease-free 10 years after diagnosis. Larry also had stage 3 oropharyngeal cancer, but died of disease 2 years after diagnosis. Why did these two patients have such different outcomes? What if I told you that Ben works for a prominent tech company in the Bay Area, while Larry worked at his local fast food restaurant? What if I told you that Ben has private health insurance coverage from his employer, while Larry didn't have any health insurance coverage? What if I told you that Ben is white, but Larry was black? This is what we call health disparities. So how do we define health disparities? The National Library of Medicine defines it as variation in rates of disease occurrence and disabilities between population groups that differ either by socioeconomic status or geography. An alternate definition that I actually prefer defines it as significant differences in health outcomes and healthcare use between socially distinct populations that are either vulnerable or less vulnerable. And what this really means is that we're looking at differences not only on health outcomes, but also healthcare use. And that these differences that are observed have to be between populations that are defined as being vulnerable versus less vulnerable. So how do we define vulnerable populations? There's several dimensions that we can look at, and we'll look at a few of them here. We can look at race and ethnicity, probably the area that's been studied the most. We can look at socioeconomic status. We can look at health insurance status. We can look at health literacy, which is an area that's often overlooked. So health literacy is the ability of a patient to obtain, process, and use information to make decisions regarding their health care. It's essentially a measure of how the patients are able to navigate the healthcare system. Another often overlooked area is also immigration status, which can affect health outcomes. And what about health outcomes? How do we measure this? We can look at disease incidence, so how often a certain disease occurs in a population. We can look at disease severity, which we're pretty used to looking at. So for example, for cancer, we can look at disease stage, so how far the disease is spread. We can look at disease outcomes, and important areas for cancer involve survival rates, recurrence rate, and quality of life. And although it's counterintuitive, treatment itself can be a health outcome, because we can look at access to treatment, we can look at the type of treatment received, whether you receive the correct treatment or not. And we can also look at the quality of treatment you receive. So before we move on, I'm just going to give a brief overview of head and neck cancer. Basically, this is described as cancer that involves the head and neck region, usually excludes the brain or the eyes. The most common sites involved are the oral cavity, so pretty much the mouth, the pharynx, which is the throat, and there are three separate areas. You have the nasopharynx, which is the area of the throat behind the nose, oropharynx, which is the area of the throat behind the mouth, and the hypopharynx, which is lower down behind and around the voice box. And then also the larynx, which is a voice box. There are several other areas apart from this that can be involved, but these are pretty much the most common sites. The most common type of cancer is called squamous cell carcinoma. The major risk factors for this cancer is tobacco and alcohol use. However, for oropharyngeal cancer, in addition to these risk factors, HPV, so human papillomavirus, is actually a major risk factor, and it's actually the most common risk factor these days. There are several factors that can impact survival from head and neck cancer. The location is important. The stage, that is how far the disease is spread, can affect survival. And the type of and quality of treatment that you receive can affect the survival. Specifically for oropharyngeal cancer, HPV status is also important, with HPV-positive tumors having better outcomes than HPV-negative tumors. Apart from these clinical factors that we talked about, non-clinical factors such as socioeconomic and demographic factors can also affect survival. And we're going to look at a few of those. First, we're going to look at marital status. A lot of studies have actually been done in head and neck cancer showing that married patients tend to present with less advanced stage disease, and they actually have improved survival compared with unmarried patients. The reasons for these are not entirely clear, but there are several potential reasons. One is probably better social support. Treatment of head and neck cancer has a lot of moving parts. There are a lot of tests that need to be done, a lot of appointments that patients need to make it to. So having somebody to help you navigate the system can be beneficial. Another potential reason is probably more resources, maybe more financial resources, but probably more important might be health insurance coverage. A lot of patients get health insurance coverage through their spouse, and that can probably lead to more timely and better access to care. A third potential cause is this phenomenon called spousal surveillance. So the likelihood that if you're living with a partner, they're probably more likely to notice a neck lump and maybe persuade you to seek care. I can't count how many times I've seen a patient that told me, hey, I've had this for a while. I didn't really think it was anything, but my spouse really wanted me to get it checked out, so that's why I came in to have it checked out. Okay? So these are potential reasons why married patients can have better outcomes. Next, we're going to look at socioeconomic status. But before we look a little bit more closely, we have to really think about what this means, because there's really no clear definition of what socioeconomic status is. However, there are three main domains that contribute to this. One is income, the other is education, and the other is occupation. And the studies that have been done in head and neck cancer have shown that patients from low socioeconomic status actually have worse survival than patients from high socioeconomic status. The interesting thing is actually the attribute of your neighborhood, where you live at, is actually as important, if not more important, than your individual socioeconomic status. And studies have shown that patients that come from low socioeconomic status neighborhoods actually tend to do poorly compared with patients that come from high socioeconomic status neighborhoods. Next, we're going to look at health insurance status. And what we find actually is that patients that don't have insurance and patients that have Medicaid insurance tend to present with more advanced stage disease at diagnosis. They are less likely to receive treatment, and they have worse survival. And this is probably because of poor access to care. Because whether you have insurance and the type of insurance you have determines whether you can access care and how quickly you can access care. The second potential reason is probably about quality of care, because the type of insurance you have not only determines whether you can receive care, but also where you can access care. Okay? And there are differences in terms of quality of care you can receive at different healthcare facilities. Finally, we're going to look at race and ethnicity. It's important for us to clarify what we mean by this. So according to the US Census Bureau, there are 5 racial categories. So you're either white, Black, American Indian or Alaskan Native, Asian, or Native Hawaiian or other Pacific Islander. For ethnicity, there are really only 2 options. You're either Hispanic or Latino, or you are not. It's very important for us to know that race and ethnicity are actually social and political constructs. They are not defined by genetics or biology. Rather, they are defined by self-identification. When the US Census Bureau sends you the census form, you are field to check off whichever racial category that you identify closely with. And you can check off more than one. And this is a very critical point, because racial differences in healthcare access and outcomes are actually not defined by genetics or biology, but rather by social and environmental factors. So let's look at what the literature has to say about race and ethnicity. Most of the literature is actually focused on looking at race. And what we find is that Black patients are more likely to present with advanced stage disease. They're less likely to receive the correct treatment, and they have worse survival when compared with other racial groups. So now we know that there are a lot of disparities in head and neck cancer outcomes and treatment access. The question is, what do we do about it? I think it's important for us to really understand what the drivers of these disparities are so that we're better equipped to come up with potential solutions. However, the drivers of disparities are very complex. Now, this figure that I have up here represents my simplified conceptual framework for understanding drivers of disparities. But as you can see, it's still very complex, right? But essentially, there are two main pathways to look at here. One of them really explains the survival differences between socially disadvantaged and advantaged populations based on differences in disease stage at diagnosis. However, we also have to acknowledge that there's still persistent differences in survival outcomes even when we account for differences in disease stage at diagnosis, which means there are several other things that are going on here. I know that I previously mentioned that these drivers are very complex, but we're going to just focus on two aspects here. First, we're going to look at insurance status, and then we're going to look at quality of care. So when we look at insurance status, what we find based on the studies that have been done is that racial minority patients and patients from low socioeconomic status backgrounds are actually more likely to be uninsured or have Medicaid insurance, which again, a few slides ago, I mentioned, these are factors that are associated with poor outcomes. And these are factors that lead to poor access to care and probably poor access to quality care. When we look at quality of care, what we found is that racial minority patients are more likely to be treated in low quality hospitals. The main question that we have to answer though is what do we mean by low quality or high quality? How is this measured? And previous studies that have looked at this area have actually used surrogates such as case volume, so the number of cancer cases that are treated per year by the hospital, or accreditation status, for example, a cancer center designation status, and they've used them as surrogates for quality. The problem is that these are not direct measures of quality of care, and we don't actually know if they are really associated with outcomes. So we're going to look at some of the studies that we've done to try to understand the drivers of disparities. First, we're going to look at health insurance. So a previous study that we did looking at oropharyngeal cancer showed that Black patients were more likely to present with advanced stage disease. They were more likely to present with untreatable disease, and they also had worse survival compared with other racial groups. So we decided to figure out whether insurance status played a role in this. And we looked at data from about 12,000 patients that had oropharyngeal cancer. And what we found was that Black patients were more likely to be uninsured or have Medicaid insurance. We also found that Black patients had increased risk of untreatable disease. However, this risk actually decreased after accounting for racial differences in insurance status. When we looked at survival, we found that Black patients had worse survival, but also the differences in survival outcomes decreased after accounting for racial differences in insurance status, indicating that health insurance status is a major driver of the disparities that we observed. Next, we set out to look at hospital quality. And the earliest study that we did looked at thyroid cancer. And we looked at almost 31,000 patients that were treated for thyroid cancer in 282 hospitals in California. And rather than just using a simple surrogate for health, quality, we actually came up with a composite thyroid cancer specific hospital quality measure that incorporated, again, case volume, so the number of thyroid cancer cases that were treated per year by each hospital. But we also looked at whether patients were treated according to national guidelines, and also whether the hospital was certified as a cancer center. And using this composite measure, we're able to stratify hospitals as high quality versus low quality hospitals. And what we found was that patients that were treated in high quality hospitals actually had better survival compared with patients that were treated in low quality hospitals. We found that Black and Hispanic patients were less likely to be treated in high quality hospitals compared with non-Hispanic white patients. We found that patients that didn't have insurance or patients that had Medicaid insurance were less likely to be treated in high-quality hospitals compared with patients that had private insurance. And we also found that patients from low socioeconomic status neighborhoods were less likely to be treated in high-quality hospitals compared with patients from high socioeconomic status neighborhoods. We did a similar study looking at oral cavity cancer, and we looked at about 7,000 patients that were treated at 308 hospitals in California. Again, we developed a composite measure of oral cancer-specific hospital quality. And we also used case volumes. We looked at treatment according to national guidelines. And then we also looked at patients that underwent neck dissection. So this is a surgery where lymph nodes are removed from the neck. And we looked to see if they've removed an adequate number of lymph nodes from the surgery, because previous studies have shown that if you've had the surgery and you don't have an adequate number of lymph nodes removed, it's actually associated with poorer outcomes. And finally, we also looked at whether the hospital was certified as a cancer center. And similar to a previous study, we also found that patients that were treated in high-quality hospitals had better survival. We found that Black and Hispanic patients were less likely to be treated in high-quality hospitals, and that Medicaid patients were also less likely to be treated in high-quality hospital compared with patients with private insurance. And when we looked at neighborhood socioeconomic status, we also found that patients from low socioeconomic status neighborhoods were less likely to be treated in high-quality hospitals compared with patients from high socioeconomic status neighborhoods. So we know that a problem exists. We understand some of the drivers. The question is, how do we go about solving these problems? And there are two potential targets for interventions here. One is to target, health insurance reform. The other will be to look at improving quality of care. And actually, some of that work regarding health insurance status has been done in the form of the Affordable Care Act. We did a study actually trying to look at the impact of Medicaid expansion on head and neck cancer diagnosis. So what Medicaid expansion is basically, as part of the Affordable Care Act, some states decided to expand Medicaid coverage to population groups that were not traditionally being covered by Medicaid, while some other states didn't. And what we did was compared those states that underwent expansion against states that didn't undergo expansion. And what we found was that the rates of lack of insurance actually decreased among patients with head and neck cancer in states that underwent expansion compared with states that didn't undergo expansion. And then when we looked at stage at diagnosis for head and neck cancer, we actually found that more cases were diagnosed at an early stage for young patients, for female patients, and for unmarried patients. And interestingly, these are actually the population groups that are at higher risk for not having health insurance, indicating that we're making some headway in that area. Regarding hospital quality and quality of care, one option in terms of intervention would be to regionalize head and neck cancer care. Basically, what this means would be having a policy that only certain hospitals that meet certain quality metrics can treat patients with head and neck cancer. And this has actually been done before, not specifically for head and neck cancer, but in breast cancer. So in 2009, the New York State Medicaid program instituted a policy that they were not going to pay for care at facilities that performed less than 30 breast cancer surgeries per year. And a study that was done afterwards actually showed that following this policy, the mortality rate actually significantly decreased for Medicaid patients compared with before this policy was instituted. Another option would be to try to initiate quality improvement projects aimed at improving the quality of care at these low-performing hospitals. And actually, these low-performing hospitals tend to be the hospitals that care most for patients from socially disadvantaged backgrounds. So in conclusion, there are significant disparities in head and neck cancer outcomes. Apart from the clinical factors that we tend to look at, other factors such as race, ethnicity, marital status, socioeconomic status, and insurance status can affect outcomes. It's important for us to recognize that these disparities are very complex. They interact with each other, and they occur at multiple levels. And the future direction of research actually involves for us to better understand what drives these disparities so that we can come up with potential solutions to this problem and test and implement those interventions. Thank you.